All right. Good afternoon, everyone. My name is Alexandra Boutros, and I am the Human Research Protection Program Director in the Division of Research and a member of the Love Data Planning Week Committee. I want to welcome you to Brown's sixth annual Love Data Week, which is co-sponsored by the Division of Research and the University Library. For those of you unfamiliar with Love Data Week, it is an international celebration of data, aiming to raise awareness and build a community to engage on topics related to research data management, sharing, preservation, reuse, and research data services across disciplines. This year's Love Data Week theme is Whose Data Is It Anyway? I would like to now welcome you to one of Love Data Week's talks by a panel of presenters who will be discussing leveraging EHRs and AI to advance biomedical discovery in healthcare delivery. Each speaker will introduce themselves during the presentation. Please join me in welcoming the panel.
Great. Thank you so much. So we're glad to be here to talk with you today about the work that we've been doing within the Brown Center for Biomedical Informatics. So here's an outline of what we'll be covering today. We'll talk with you about the research we're doing in our labs, some of our educational programs, and some of our service activities. We have four of us who will be presenting, who will introduce themselves as we get to their parts in this presentation, and I will be starting us off. So I'm Liz Chen. I'm a faculty member in the Division of Biology and Medicine. I head up the Brown Center for Biomedical Informatics, or what we refer to as BCBI. And I also lead the what we call the BIBCE Core, which you'll learn more about or hear more about later in the presentation for the advanced RI-CTR program. We thought we'd start off with just, what is biomedical informatics? This is something we oftentimes get asked. And so here is a formal definition that our community came up with. And so we are a highly interdisciplinary field, or what we might refer to now as transdisciplinary field, really taking from other disciplines and bringing methods, theories, and techniques from those, as we can see some of them on the right, together, all with in an effort to really effectively use data, information, and knowledge with the ultimate goal to improve human health. So a pretty broad definition, and we really do many different things, but all really trying to improve human health through effective use of data, information, and knowledge. Sometimes we'll ask in our courses, how old is our field? So it actually dates back to the 1950s. Our history and methods run parallel to those in computer science, particularly artificial intelligence and databases. And a lot of things that we thought about, like we theorized back in the 1950s, we're now able to put into practice through advances in computer and communications technology, and just really many technological advancements, particularly within the last few years. On the right is just a graphic of, there are actually many subdisciplines of biomedical informatics, and what's common among these subdisciplines are the methods and the way we may apply them to different types of data, whether or not it's molecular data more in the translational bioinformatics space or population society getting towards public health informatics. And so what we do in BCBI is really in the more the health informatics area, and some of us are more focused on clinical side and electronic health records. That's what you'll hear more about today, how we use that both for clinical purposes as well as public or population health, and really draw upon these different disciplines as shown above to actually do the work we need to do. So in terms of the vision and mission, so BCBI was founded in July 2015, so we're getting close to our 10-year anniversary. And really our ultimate goal is to advance biomedical discovery and healthcare delivery through informatics science, practice, and education. We have a fourfold mission, all, if you've noticed, beginning with I for informatics. And so thinking about how do we innovate how data, computing, and technology are used in biomedicine and healthcare. How can we then take these innovations and implement them in digital solutions? Our ultimate goal is to impact health and healthcare through data and technology-driven solutions. And we really do have a strong educational and training mission, is really trying to inspire the next generation of biomedical researchers, healthcare providers, and consumers. And so how do we do this? We have three major areas. We do research, education, service. You'll hear mostly about research today, but we'll touch upon some of our education programs, our service activities. And really the foundation for a lot of this is this key infrastructure that we refer to as the health informatics, data science, and AI infrastructure that you'll also hear more about towards the end of this presentation. Who are we? So we have three core faculty that are part of the center who you'll be hearing about our work today, but we do have many collaborators, other faculty collaborators across the university, as well as with our health systems that we actively work on with projects. We also have staff, both administrative and technical and research staff, who work with us on our research, education, and service activities. And we also have a great cohort of students who we've been training since we started back in July 2015. So currently we have about 40 medical undergraduate and graduate students working with us. And you'll hear about some of their work today. And we have many alumni who have kind of worked with us in different respects in different programs throughout the years. Much of what we do, and really the topic of today's presentation, is working with EHRs and AI, artificial intelligence. So on the left is a graphic showing, this what we refer to now as a learning health system, and showing how data that's collected at the point of care as providers are caring for patients, those data are going into electronic health record or EHR systems. That can be demographics, it could be diagnoses and conditions like what diseases a patient may have, medications they may be taking, things about their vital signs, and just really a wealth of different health information about those patients. Those are all going into our electronic health records. And then there are many secondary uses of this EHR data. We can use it for research. We can use it to populate disease-specific registries, both locally, regionally, nationally, and we can learn from that data. And so there are many techniques we can use to transform data to knowledge, statistical techniques, AI techniques. And then ideally, what we can do is turn that knowledge into practice. So we might learn new standards for prevention and treatment. We can come up with new guidelines and educational materials and kind of put them back into practice in the EHR, which could be something like clinical decision support. Can we identify at-risk patients, set alerts, reminders, and that goes back into our EHR that the clinicians can then use to care for their patients. And this is a cyclical process, the learning health system. Looking at kind of layering AI with the learning health system, this graphic on the right shows that, within Rhode Island, there are a number of health priorities. We can use data, knowledge, and practice to address them. And the role of AI is we can take health data we can discover, so we can transform EHR data into knowledge using different AI methods like natural language processing and machine learning. We can develop predictive models for different conditions. And then we can implement by putting clinical decision support tools back into practice. So use those AI models to build AI-based clinical decision support tools. And then we don't want to just build them. We need to know that they're actually working. So what's the impact of those tools? So how can we study the outcomes of clinical decision support tools in the EHR? And that continues the learning of the health system, leveraging AI techniques. So in terms of research, we have students who are actively working with EHR data as well as AI techniques. You'll hear from Amina later on in this presentation. We also have some students who have recently graduated who have just actively been working in this space. And so on the right shows some of the EHR data that they've been able to incorporate in their PhD studies from our health systems, from national resources like All of Us. And you'll hear a little bit about each of these, and also using different computational methods. Some have used natural language processing or NLP, some have done machine learning, deep learning, and really looking at ways and more recently, LLMs. And so you'll hear a little bit about each of these throughout this presentation. And with that, I will hand it over to Dr. Sarkar to talk about his lab.
Thanks, Liz. So my name is Neil Sarkar. I am also on the faculty in the Division of Biology and Medicine, as well as have a secondary in the School of Public Health. My group focuses on the full spectrum of biological to healthcare to public health data, largely focusing in on the development of methodologies, formal frameworks, for representing knowledge such that computers can understand what's going on in terms of clinical phenomena, especially in the context of complex diseases as we think about healthcare delivery and public health reform. And also as you look across the United States, you look at the range of ways that care is delivered, way that folks have access to care, and also the cultural differences that represent our nation. And so my work focuses a lot in trying to understand that from a methodological perspective, going all the way into down to individuals' genomes, up to looking at things from a population health perspective. Most recently, my team has been focusing in on building a bridge between ancient medical principles, especially those as represented in ancient Greek medicine, Ayurveda, and traditional Chinese medicine. Ayurveda is from the Indian culture, and building knowledge frameworks that actually take the ancient knowledge and make it in a way, organize it in a way such that it can be actually computed upon and put into clinical decision support in a allopathic or osteopathic, or simply put, a Western context to support clinical decision support. Broadly speaking, that is within the realm of lifestyle medicine, so the American College of Lifestyle Medicine, and aligning with those factors that we look at in the context of lifestyle medicine, and how that can actually be used to impact either chronic or complex conditions, with a specific focus on nutrition. And then when we think about those as interventions and ways that we might impact improvements in care, we also at the same time have to understand what's the population that we are seeking to serve, and what's the adherence to guidelines clinically for things like cardiovascular disease, for cancer prevention, as well as other conditions that we know that start earlier in an individual's health trajectory. Are there ways for us to make sure that we are following the guidelines that are recommended by the various clinical colleges, and look for variation across populations, whether it's at the local level due to different practices within health systems, or nationally due to cultural or other factors that reflect the diversity of our country, as well as accounting for rurality. And so as we look in more rural parts of our country, there's different practices that are used versus those that are used in more urban environments. And ultimately, I seek to, and my team seeks to identify what are those social drivers that we can actually use for predicting risk for disease. And ultimately, much like those who are in the payment part of our of healthcare, trying to understand those individuals who may be high utilizers for healthcare earlier in their care trajectory, and then coming back to what we are looking at focusing in on from are there interventions, and particularly looking at holistic remedies that my team has been working on for the greater part of 2 years at this point. Next slide, please. So in particular, we are focusing in on right now on looking at traditional Chinese medicine and dietary guidelines for supporting care and care treatment. And so taking what traditional Chinese medicine therapists will use, and in terms of guiding treatments, and looking at how in traditional Chinese medicine, how different foods in particular are organized according to their energetics, as well as the mechanisms by which they are used to intervene on an individual's health, and linking that up into the context of all foods. Very much aligned with an international consortium that's looking at the organization of all foods through something called Food On, which is an ontology for foods. My team is developing something called the Food as Medicine ontology, where we're looking at foods as a medicinal ingredient and defining the medicinal uses according to ancient medical frameworks. And right now we're looking at this through the context of Chinese medicine. Next slide, please. So after we've identified, part of my team is identifying techniques for organizing ancient medical and holistic practices that many use across our country, across the globe. How do we line that up with in the clinic, pharmaceutical practices or other interventions. And that requires us to understand the overall framework through which healthcare is being manifested in our country. We start with the triple aim, so looking at improving health through the use of various approaches, and in our case, it's through the use of data, lowering costs of care by providing better preventive care, identifying opportunities where guidelines aren't adhered to. So for cancer screenings, where cancer screenings are not seen being done at the rate that we would expect to see them or want to see them according to clinical guidelines, and then ultimately providing better care for individuals. And these three areas synergize with each other as the triple aim for overall for how we look to seek to improve care across our nation. The majority of our data now is shifting to looking at the entire country through the NIH-based initiative called All of Us, which has electronic health data as well as genomic data, as well as survey data, as well as a whole multitude of other kinds of data like wearables, environmental factors, et cetera, organized into a common data framework that allows for us to look at trends across our country. And what makes the All of Us program particularly valuable for this kind of work is that it is, by its design, aiming to reflect the diversity of the United States. Diversity in terms of rurality versus urban, diversity in terms of culture, diversity in terms of socioeconomic status, and many of the factors that we know drive healthcare and healthcare outcomes. But there are very limited national data sets, actually anywhere in the world, that bring together these kinds of data into one resource. A project that is in the process of being launched by the National Institutes of Health as part of the All of Us program that started about 3 years ago and is now starting to recruit some of the first individuals into the program is Nutrition for Precision Health. And so now, if we take data about what individuals are consuming as part of their diet, how does that link up to their genomic profiles, their other clinical risk factors? How does that actually line up with overall clinical outcomes? And one of the areas that we're particularly keen on looking at is, can we provide therapies and recommended regimens that link up with clinical recommendations? So, for example, the American Heart Association recommends certain types of diets in the case of patients who have particular risk factors for heart disease. And so there's recommendations for certain types of food that should be fit into those diets. Can we use traditional approaches to guide what foods make the most sense for particular clinical interventions? And as we think about this through an informatics lens and what we're trying to do with building data models and artificial intelligence services, gathering data is shown here on the slide from the right that's taken from the National Academy of Medicine, a recent report from them that looks at how we want to advance primary care. As we gather data, pull all this together, can we develop custom tools, digital health interventions that actually can be put either into the patient's workflow in terms of how they interact with their health data, their provider organizations, also in the clinician's workflow, so they're able to actually offer more customized regimens to support better healthcare outcomes and link them to social services and other things that we, as a nation, are increasingly putting more and more energy into, as well as funding to support things like food banks and the like, and making sure that the right foods are available to individuals at the point where they actually need them and actually are at a population level looking at providing interventions that we know work at scale. And so, for example, in New York City, there was a citywide initiative that was led by their mayor that was focused exclusively on diet and diet interventions. And so how do we take that true experiment that worked in New York City and how do we scale that nationally? And are there ways that we can take knowledge and frameworks from ancient cultures that looked at diet as a core facet in the practice of healthcare and embody that in contemporary medicine? So that's what my group mostly focuses in on. I think I'm going to hand it over to Professor Fraser.
Thank you, Neil. Hi, I'm Hamish Fraser. Oops. So I'll start the video, yeah. So I'm Professor Fraser. I'm also Associate Professor of Medical Science and Health Services Policy and Practice at Brown University. And I have two really major focuses in health informatics. One is in global health informatics and looking at the ways that we can build and support and evaluate informatics tools, particularly electronic health records in low and middle income countries, and particularly focusing on the OpenMRS open source EHR system that we started actually 20 years ago last November, and is now used actually in about 80 countries. And also looking at the ways that we can improve quality of care for patients, particularly with HIV. And this includes a NIAID grant from the NIH to support using machine learning to improve decision support for HIV patients in Kenya at the AMPAF project. This unfortunately has been a very tough last few weeks for there because they were shut down from trying to use healthcare delivery due to the USAID situation. But fortunately, the medications are now being given to patients, and we're hoping to see the system and the clinical care restored there. One of the key tools, though, they've been able to use is to develop a very quick additional form in the EHR that records medication pickups for patients and just very limited check-ins so that they can rapidly screen patients and keep track of those who might need additional care later. And so this is a key part of our work, and we really focus on also interoperability between different systems using FHIR and have sites working with that as well. Next slide, please. The other key area of my work is in diagnostic decision support, particularly to focus on improving healthcare quality and the impact of poor diagnosis, which Amina will be talking about in a minute. And this includes looking particularly at the way that patients interact with online systems for diagnosis. And this includes symptom checker apps using online tools like Google, but in particular, of course, over the last 2.5 years or 2 years, we've been focusing a lot on large language models like ChatGPT and studying the way those systems can be used by patients and whether that's a good idea or not. So at this point, I will hand over to Amina, and then I will follow up with a couple of more slides afterwards.
Thank you, Dr. Fraser, for the introduction. Hi, everyone. So today I'll be talking about large language models and their use in diagnostic decision support. So firstly, I'll delve into the area of large language models by talking about the burden of diagnostic errors. So this infographic here tries to give us an overview of the burden of diagnostic errors. Specifically, it shows that nearly every person will experience a diagnostic error in their lifetime. And it also shows that 18 million diagnostic errors are made each year. In summary, Liz, you need to go to the next slide. In summary, it's just trying to say that diagnostic errors are a leading cause of death. And that's not much of a bad news because there's some good news. Diagnostic errors can be improved. The next slide, I have like a animation. Yeah. So diagnostic accuracy can be improved by consulting multiple physicians or using automated diagnostic tools. But unfortunately, in the real world setting, we don't really have the luxury of having multiple physicians attending to a single patient at a time. That's why studies have suggested the use of automated decision tools to complement a physician in the diagnostic process. So you can move to the next slide, please. So how are these diagnostic decision support tools built? EHRs facilitate the use of these tools in the diagnostic process. Specifically, if we have an EHR, this you can, yeah. An example of an EHR is a patient's clinical note. We can use this EHR to learn a machine learning system and learn this model to train it to be able to give us a rank list of diagnoses depending on the patient's case. A very popular example of a tool that's currently being used now is ChatGPT. So ChatGPT can be prompted. So a prompt is a question with a clinical note, and we can expect this model to return a rank list of diagnoses. In summary, EHRs has facilitated has led to the development of symptom checkers and the use of large language models for clinical decision support. But we have some pressing questions. Can these large language models perform complex diagnostics, sorry? We ask this question because these ChatGPT-like models have seen massive popularity in recent times. In fact, they've been used in medical licensing exams, but studies have shown that these exams can be aced via memorization. Meanwhile, real patient condition involve numerous variables and uncertainties. And these models are accessible to patients. It's accessible via your phones. It's everywhere on the internet. So we need effective strategies to evaluate these tools to see if they are ready for patient use. So I'll talk about, So in this slide, I'm going to talk about what we did to evaluate these models in the medical setting. So this paper was actually published last year in JMIR. The main question we wanted to ask is, how can we trust this model's responses? Imagine a patient use this model, asks a specific question in a specific format, and ask the same question in a slightly different format. So those are the different approaches we have here. So a prompt strategy just means we ask the same question, just using slightly different format. So we feed this different format to the language model. So we expect that since it's the same question, the responses should be the same. So we come up with the majority voting to measure the confidence of the model, or to measure the consistency of the model. So we feel like since we're asking the same question using different approaches, we expect the model to be consistent in its response. We evaluated this model using New England Journal of Medical Science case challenges. So these case challenges are diagnostic cases that are published online, and doctors and other clinicians are usually invited to come up and predict the patient's condition. So we collected these different cases, and we collected the human average responses, and we fed these cases to a suite of different large language models to see if they'll be consistent in their responses, depending on the question or the prompt or the diagnosis. So we tested Google Bard, GPT-4, GPT 3.5, all represented with different colors here. And if you look at the different approaches, you can see there's a variation in the performance of these models. But some of the major takeaways here is that if you look at approach 2 and 3, these models have the potential to perform similarly or even better than the average human consensus. But if you look at approach 1, these models don't do so well. And if you look at the majority voting, you will expect that they'll be consistent in their responses since we're asking it the same question, but just using different approaches. But it's not the case for most of this model, except the GPT-4. What this means is that how will a patient know which of this approach to use beforehand? What if a patient uses approach 1? This leaves a burning question. Are these models ready for the deployment in the real world setting? Should these models be used by patients since they are not even sure which approach will give them the best from these models? So I'll move on to the next slide to give my key takeaways. EHRs has facilitated the development of automated diagnostic decision support tools like large language models. We see that these large language models like ChatGPT have the potential to improve diagnostic errors, to improve diagnostic accuracy and reduce errors, but they are sensitive to formatting. How can we know the best way to use them? So further research is needed to optimize these models in patient care. We need to understand if they can be reliable, are they safe to use, are they accurate enough? So this is what our lab tries to do. Yeah. Thank you.
Thank you. So that's Tassa Abdullahi, middle name Amina. So that's why the name doesn't quite match, but thank you, Amina. And that was really helpful because what I'm going to do is just follow on briefly with some similar experiments, which we've been doing, some of which Amina has been part of actually, and key player, in fact. So really the question is, we've got this explosion of medical AI in all sorts of different approaches in medicine, a lot of interest in this. Just when we thought this boom might go down a couple of years ago, that maybe it reached its peak, of course, along came ChatGPT and turbocharged the whole thing. So we've got this interesting problem that long-term experts like Pete Solovich at MIT, who are experts on clinical decision support systems, really don't know for sure what's going on with these models. How is it they're really good at diagnosis? Because it doesn't make a lot of sense since it was trained primarily on a whole range of documents from the internet and not really medical data in particular. So it's a fascinating thing, and there's clearly some very important potential there. But really, as Amin was saying, it's really important to understand how safe and reliable they are in clinical diagnosis and triage. And that applies both to clinicians and other healthcare workers using, but also patients. So this work is funded by the HRQ as one of my grants. Next slide, please. So this briefly is some of the work we did where we collected data using an ADA symptom checker app in Rhode Island Hospital. This was actually 4 or 5 years ago now. And patients came in, they were consented to use the system, entered their data, the diagnosis and triage data was sent to the research team. And then we compared the results with the final diagnosis from the clinician who saw the patient. And we also collected the data and used that to test other algorithms and also clinicians who just saw the data. And we can see there's actually quite a range of different performance here, but this was the original version about 1.5 years ago with ChatGPT-4. 4 was actually not very good. 3.5 was good for diagnosis, but actually was quite bad for triage. Next slide, please. So very recently, one of my students, Kenyon, who is doing his undergraduate thesis in this area, has been looking at ChatGPT 4.0, which is the latest general version of ChatGPT. And we also had a look at DeepSeek, this new model that just came along in the last 2-3 weeks, to kind of get a sense as this overlap between the different model types, the different versions, and also, of course, the prompts, as Amina said. And what was interesting here was that in the data, we have, first of all, a standard prompt, which asks the 5 most likely diagnoses, and then also 3 levels of triage: home care, routine medical care, or emergency care. And what we found was that the best results for ChatGPT were actually with a very simple prompt: what is the diagnosis, which is a little surprising. The more complex, detailed prompts, like what we call the medium prompt here, didn't do as well. And the standard prompt we've used a lot in other studies actually wasn't that great. Here we see DeepSeek getting kind of similar results, maybe slightly better on the standard prompt, not quite as good on the simple diagnosis prompt. But we feel that the question is, patients, what diagnosis and questions would they be asking about? And it's very unlikely they would know how to prompt the system properly. So asking what is the diagnosis or something about what follow-up care is needed might be the only thing that they would generally enter. So that's a real concern, because you can see quite a variation just by these small changes. Next slide, please. And this is actually looking at triage across the 40 cases in this group. And for different versions, ChatGPT 4.0 with what is the diagnosis, with a standard prompt that also asks about triage, and then this more medium prompt. And the red ones are underdiagnosis, so potentially unsafe, and yellow is when it's actually overdiagnosed. And you can see there's quite a variation between the different prompts in the same systems. And these 2 prompts actually are the same, but with the different algorithms. So you can see that in this case, the standard, the very simple prompt for the diagnosis actually does badly on triage. Next slide, please. And those numbers here are just rather off the price. We just did this last week. But essentially what it shows is that the overall performance of DeepSeek is actually fairly good on that standard prompt compared to the other version of ChatGPT. But the best triage performance is probably on the medium prompt. Okay. And next slide, please. Finally, I'll just briefly talk about another study which was actually presented by a number of the team. Anita Zahiri, who's an undergraduate PLME student. Also, Ishani Khatri, a medical student, was a lead on this. And Amina did very key work here as well. So next slide, please. What we're doing here is looking at a whole data set of about almost 1,500 patients admitted to the Rhode Island Hospital TA and Stroke Observational Unit over the last more than 10 years or so. And what we're looking at was how well could you diagnose whether a patient should have basically emergency care recommended by ChatGPT, and also whether it actually had the correct diagnosis of stroke or TIA. And we compared the results with the results from a neurologist who actually reviewed the cases and provided a very accurate final diagnosis based upon neuroimaging. Next slide, please. So very simple results here. What we're doing at M1 is the top diagnosis list, how well that matches. M3 is the top 3, and M5 is the top 5 diagnoses. 3 different data sets. One using ChatGPT-4, which is actually the API. The other is actually cases entered directly, 100 cases entered directly into ChatGPT, as opposed to the data set entered into automatically into the API. And then also we looked at an earlier study we did in primary care with ChatGPT-4, just to give a sense as to how well this might work overall in performance. And we can see that actually performance is fairly similar, but surprisingly, the API version in this case does better, but in other cases it actually does worse. And when we look at triage, we find, next slide, please, that there's some real concerns here with running the results on the full data set, where the ChatGPT version is pretty accurate in terms of triage. It really gets every single case. However, the GPT-4 emergency triage was not nearly as good. And in fact, only 82% were correctly triaged. And we've seen worse results with some different prompts. So overall, we're seeing big variations and potentially unsafe, situations where the triage is really very badly off for emergency diseases. So an interesting question about how do we ensure these things are safe? Okay, and I'll hand over to the next.
Great. So I'll just kind of wrap up research. And so this is just a little bit about my lab, the Clinical Informatics Innovation Implementation, or CI3 lab, really focused on the EHR, both the technology and data to improve healthcare delivery and biomedical discovery. On the left kind of shows the work has been done in my lab over the last 10 or so years, and in terms of data sources, really focused on the EHR, but also delving into other data that are out there, looking at literature, things like claims data. Methods have also kind of worked with a series of methods, but primarily data mining, looking for patterns within data, as well as natural language processing, trying to pull out information from text. And particularly focused in areas like determinants of health, mental health, pediatric health. Some projects have focused on one of these areas, some cross up the two, and some also working across those 3 areas. So for example, on the right, this is a study that one of my PhD students who finished her PhD, but specifically looking at the autism spectrum disorder, those kids with autism spectrum disorder, characterizing them from EHR data, as well as looking at trying to predict suicide risk, particularly for those who have encounters with the pediatric psychiatric emergency services at one of our health systems. And this overview just shows kind of that standard process or pipeline to go from data to knowledge. And so starting with data from the electronic health record at one of our health systems or Brown affiliated health systems, looking not just at structured data like demographics and diagnoses, but also looking at unstructured data, because a lot of the information, particularly for this service, is just found in this evaluation note is taking at the point of care. Then doing a lot of data pre-processing, trying to figure out who are patients with autism, trying to identify cases of suicidal thoughts and behaviors based on the data that's provided both within the structured and unstructured data, looking at different features within the notes, using, in this case, we use pretty lightweight natural NLP techniques to extract that information, and then being able to do analyses from just basic descriptive statistics to doing some machine learning for prediction tasks, and trying to figure out what are the features that are most important. And so really bringing together EHR data, machine learning, and NLP in this work. So that's a bit about kind of the research that each of our labs is doing. We thought we'd end the presentation just talking about the education mission of the center and some of the programs. So our first program, we started up the center in 2015, is the Scholarly Concentration in Biomedical Informatics. I'll talk a bit about that. That program focused on medical students. And over the years, we've partnered with other graduate programs to do for MD, PhD, and PhD students. For undergraduates, they're as part of the biology track, biology concentration. We do have a track in biomedical informatics, and I've seen interest in that grow over the years. And more recently, through Dr. Fraser's lab. We're supporting a global health informatics fellowship, and then we will be starting a master's program in health informatics this fall. What brings these programs together are these competency areas. So these 7 competency areas really underlie all our programs. And so really providing the training or the education so that these students have both knowledge and skills in health and healthcare, in data science and AI, also health information technology and digital health, and also complementing that social and behavioral science, thinking about kind of the ethical uses of like AI and these different technologies. And then coupling that with professionalism, leadership, and team science skills, because as informaticians, we're really all about team science. We're always working with those from different disciplines and trying to come up with solutions together to improve healthcare delivery and biomedical discovery. These programs are supported by a range of courses, those for medical students, undergraduate students, graduate students, and also more recently healthcare professionals through a master's in healthcare leadership program, and really covering both EHRs and AI and all the topics in between and those that are in the field of biomedical informatics. So just a little more about our scholarly concentration in biomedical informatics. So I think similarly, just like the center, we're going on almost 10 years of training, working with medical students. And so this is part of a larger scholarly concentrations program in the medical school, really trying to give medical students the opportunity to do independent scholarship, work with mentors throughout their 4 years in a medical school. We are one of 13 scholarly concentration areas. And have really ranged about 5 to 10 medical students per year working with us. And so the overall goal of our concentration is for the med students to gain familiarization with the breadth of informatics and data science principles. So really getting those foundational skill knowledge, and then be able to put this knowledge into practice, develop solutions. Many of them have been AI related solutions to address a specific biomedical or healthcare challenge in collaboration with experts both across Brown as well as our affiliated health systems. And just to give you a sense of what these students are working on, this is our latest group of students, MD27 students. Here's just 7 of their projects that they've been working on, and you can see some have worked with machine learning, some with NLP, and you kind of see it really goes the spectrum of different clinical specialties, different conditions. And also some of them have worked with imaging data, some with, note data, other types of structured EHR data, and some have also worked with other data sets like claims databases. So really just a spectrum, and we're very proud of this program and have built a lot of the infrastructure through our work with the medical students. We also do service in addition to research and education. And so this is our effort to really help the broader research community across Brown as well as across Rhode Island by providing leadership and operational support for health data and technology-driven research. As one of our main groups that we work with is the Advanced RI-CTR program that's focused on providing resources, services, and training for clinical and translational research across the state. We are heavily involved with the BIBCE Core. It has a very long name. I'll just say the BIBCE Core. And so some of the things we do is we provide consults. We work with researchers. We collaborate with researchers, particularly those who want to use EHR data in their work and thinking about things like data standards. We help them think about best practice for how to extract data, how to manage the data, and also think about how do we protect the data privacy and security. Also, to things like AI, how do you actually use AI techniques to learn from data, but also how do we build AI tools? We also provide mentorship to researchers and also training in a variety of areas. And then finally, resources, things like REDCap that's used for research data collection, and some of these tools, Julia R, Python, SQL, all of these are commonly used tools for health data analysis, all open source. And also really trying to align with international efforts, particularly the Odyssey consortium, that observational health data sciences and informatics that establishes tools, standards, and tools for doing work with EHR and other types of health data. Just to tell you a little bit more about our URSA initiative, or the Unified Research Data Sharing and Access Initiative. We actually had a whole panel on this earlier in Love Data Week on Tuesday. And so this is really our effort to facilitate EHR data sharing and access in Rhode Island. It's really a team effort involving many groups across Brown and our health systems and health data partners to think about things like the technology aspects, compliance, legal, and research aspects of doing data sharing and access. And what we think a lot about is cross-institutional data governance. How do we make sure we're sharing data appropriately and protecting the data and the patients, thinking about cyber infrastructure, so the technology needed to do this, and also the training, because this may be new to you or new to researchers. So how do we make sure we securely access and use EHR and other health data for research purposes across Rhode Island? And so on the right, these are just a few examples of local or regional EHR data sources from our Brown affiliated hospitals and clinics. Mimic is an example of a de-identified data provided through Beth Israel Deaconess Medical Center up in the Boston area. And then you heard a little bit about the All of Us researcher workbench. So there are national EHR data that have protections in place to enable use for research. And so, in the last few minutes or few slides, just say, all of this has required establishment of what we'll call the health infrastructure. So we've brought in the term to health informatics, data science, and AI infrastructure. This is really what the EHRs initiative has been about. 10 years ago, there was not much infrastructure to do the kind of work that you've been hearing about throughout this presentation. And so that's what motivated starting up this EHRs initiative and really trying to align with best practices in the community, in the informatics and data science community through the Odyssey program. And this has been through advanced RI-CTR-N, BCBI, as well as working closely with our Office of Information Technology, the University Library, and the Division of Research at Brown. And so there's a lot on this diagram, but just to kind of show you all the things that we really need to think about and do to be able to do research and education service in this space. So at a fundamental level, we want to be able to access data securely. So here are just some of the examples, some that you saw on the previous slide, others are other data partners we've worked with over the years. But we really need to have, at a foundational level, data governance. We need to make sure we're using that data appropriately. We have to have place. And so within a governance structure, we think about things like making sure we get quality data, making sure we know who is responsible for the data, thinking about data protection and compliance, and how do we actually manage data throughout its life cycle. And at Brown, we're fortunate we have great computational resources. So we have computing environment, Stronghold, and Oscar that we've been able to leverage over the years, both for working with sensitive data as well as doing training with the data that we support. And more recently, we're starting to see, cloud environments as being opportunities to do work. And so all of us, that's an example of they leverage cloud technology to be able to do what they need to do. In between here, standards are critical. Oftentimes the things you really don't think about, but codes, coded data, things like that, things like ICD codes and things like that, those are all really critical so that we can actually share data appropriately and have generalizable and reproducible results. That kind of falls in between there. Then you have your data, but how do you actually work with it? And so that's where different computing and software comes into play. So needing to have kind of that knowledge of different tools and different software that you may need to do analysis of your data. You need to also think about how do we ask for the right data? We don't want all data, but how do we ask for it in the appropriate way to get just what you need for your analysis? And there are best practices for this and how to do that. And then finally, this is where after all these layers, you can actually do your analysis, whether or not it's a statistical analysis or it's a deep learning analysis, or you're trying to build an app. There are formal frameworks to do this. And then this is our layer of, we're thinking a lot about, resources for the research community, events, training. And so we have been building up over the years training manuals as well as courses to be able to help researchers think about all these different layers and to be able to do work with health data in the appropriate way. And so in this example, these are some of the trainings that we have started to offer, particularly through these supplements as part from Advanced RI-CTR, and this has involved working with community partners in Rhode Island, particularly RIPEN, the Rhode Island Parent Information Network, and Progreso Latino. And so we will be offering these 5x5 workshops over the summer. And it's basically 5 topics in 5 days. We talk both about things you need to know as well as how to actually do it. So taking what I showed on the previous slide and saying how to actually put that in practice and give you a real world experience using a training environment, training data that we've been developing over the last few years. And then what supports this is the Kodiak for Health. And so we have a Love Data Week theme for the Kodiak. That's an online resource that we'll be building up over the years, and also biocomicals, which are web comics about science and medicine. So how to make these topics accessible more broadly. So I think with that, that's what we had for you for today. We thought we'd just talk about what we've been doing. And you can visit our website, reach out to us. The links are there for both BCBI as well as Advanced RI-CTR. And the contact information for all of us is on this slide. And I think we have a few minutes for questions if there are any.
Hi, Liz. I have a quick question. This was an excellent presentation and a really great overview of all the amazing work that you're doing here at Brown and in the community. I have one question, and it's a weird time to ask this question, but the question I wanted to ask is about the relationship with the center and the federal government through, for example, like data interoperability standards. I didn't know if your center had been really involved previously, not now, but in the previous administration, working on standards for interoperability for data and advising in any type of way on policy around data and EHR.
Yeah,
I can take that. So, in addition to my role here at Brown as a faculty member, I also run the state of Rhode Island's Health Information Exchange Organization, or a regional health information organization, an organization called the Rhode Island Quality Institute. As part of that, we're heavily involved with the Office of the National Coordinator, now the ASTP, the Assistant Secretary for Technology Policy, part of HHS, which oversees standards and the like for EHR data. One of the things that we do at the Rhode Island Quality Institute, and we've engaged students and others on this, is assess the interoperability readiness of our state. And so as data come from all across, there's 5 major health systems, but there's really, practically speaking, about 50 health data sources across our state. The data come through, and assessing the quality of that data and how that aligns with what the federal government is recommending EHRs provide, or lab systems provide, or imaging systems provide, and what that actually looks like boots on the ground. And it's a complex discussion. We don't have time today to go into all the details, but there's a lot of challenges because a lot of the standards as they're implemented are really driven by the vendors and less so by the clinical uses or even the research uses. It's driven by the vendors, and that's where the health information exchange, and we're in the process of transitioning to a new technology vendor called CRISP, which actually is heavily involved at the federal level in some of the discussions with ASTP, as well as our trade organization called Civitas. Hopefully that at least gave you a little bit of an answer.
Yeah, it did. Thank you very much. And again, a really excellent presentation. I learned a lot.
Any other questions? Okay, I think we're good with time, but yeah, thank you all so much for joining. It's been great to be able to talk about, what we've been doing, and we also look forward to collaborating or connecting with any of you who may be interested in learning more. So just, yeah, feel free to reach out to us. And yeah, thank you. Yeah, also to the Love Data Week organizers for everything that you've done to put together a great week of events. And we're glad to be able to do this on your last day of the week.
Thank you.
Everyone. Thank you.